Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
Welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCOPO articles. I'm your host, Dr. Rafeh Naqash, social media editor for JCO Precision Oncology and assistant professor at the OU Health Stephenson Cancer Center, University of Oklahoma. Today, we are joined by Dr. Amit Mahipal, professor of medicine and director of GI Oncology at the Case Western Reserve University in Seidman Cancer Center. Dr. Mahipal is also the author of the JCO Precision Oncology article titled Tumor Mutational Burden in Real-World Patients with Pancreatic Cancer, Genomic Alterations and Predictive Value of Immune Checkpoint Inhibitor Effectiveness. Our guest disclosures will be linked in the transcript. For the sake of this conversation, we will refer to each other using our first name. So Amit, welcome to our podcast and thank you for joining us today.
Thanks for having me here.
Excellent. We came across your article in JCO Precision Oncology, and it really aroused my interest because the topic and the audience that it caters to is very important in the current times, because immunotherapy generally is considered, pancreas is considered the graveyard for immunotherapy, in essence, based on what I have seen or what I have encountered. And now you're the expert here who sees people with pancreas cancer or done a lot of work in the pancreas cancer research side. So can you tell us the context of this work and why you want to look at immune checkpoint inhibitors in pancreas cancer?
Absolutely, Rafa. As you mentioned, pancreatic cancer is considered what we call quote unquote cold tumors. So they don't typically respond to immunotherapy. And when we talk to our patients or patient advocates, as you know, patients are very excited about immunotherapy. Immunotherapy has transformed the treatment for a lot of different cancers, and not only has increased survival, but the quality of life is so much different than with chemotherapy. So this work came from because based on the Keynote 158 trial, which was a tumor agnostic trial, which accrued patients who had TMB high tumors. And what that means is tumor mutation burden more than 10 mutation per megabase. And what happens is, because of that trial, more than 200 patient trial, FDA actually approved this immunotherapy or pembrolizumab as a single agent pembrolizumab for any patient with solid tumor who has high TMB, again, tumor mutational burden more than 10 mutation per MB. And then this question comes in now, does this apply to our pancreatic cancer patient group, especially as we know, these are cold tumors that typically do not respond. There have been multiple trials looking at immunotherapy, single agent, dual immunotherapy agents, as well as combination with chemotherapy with somewhat very, very limited success. So that was kind of our basis. So we wanted to look at in this retrospective kind of review of a big database to see how many patients we can find who have high TMB, and then kind of see in that patient population, is immunotherapy really active based on the FDA approval, or is pancreatic cancer not a tumor where we should try immunotherapy even in the selected group?
Thank you for that explanation. I'm taking a step back again, since you see these individuals with pancreas cancer, I imagine day in and day out, and you're in the space of drug development. What is the general current standard of care approach for individuals with pancreas cancer in your clinic? And I'm talking about what are the most common approaches that you utilize that seem to be working or have FDA approvals in the pancreas cancer space?
As with any tumor, the first thing is obviously staging. So depending, we're talking about early stage versus advanced stage, and what are the goals of treatment is. At this point, the only thing that can cure pancreatic cancer patient, what we really consider conventional therapy, is surgical resection. So any patient who is a candidate for surgical resection, that puts into a different bucket compared to advanced patients. And for obviously early stage patients, we try to actually do what we call neoadjuvant treatment or neoadjuvant chemotherapy to shrink the tumor or at least maintain it, look at the biology of the disease, and then take them to surgery, which is typically involved like a Whipple procedure if it's a head of pancreas mass. Now, moving on to the advanced patients, that's where we know the goal of the treatment is palliative, is to increase the survival. But unfortunately, most of the times we cannot cure them. And there, the standard of care options include systemic chemotherapy. We have two typical regimens that we use. One is called FOLFIRINOX, which is a 3-drug regimen of 5-FU-oxaliplatin and irinotecan. And another regimen is called gemcitabine plus Abraxane, which is a 2-drug regimen of gemcitabine plus Abraxane. And these are considered standard of care. Unfortunately, the median survival, even with the best standard of care chemotherapy, is about a year, 12 to 13 months, depending on what trials we look at.
I still remember some of these regimens from my fellowship where we used to decide which to give to which individual based on, their performance status and clinical status, etc. But now I can see a lot of ongoing drug development in this space of pancreas cancer. I'm guessing that's why you wanted to assess both the molecular genomic landscape of pancreas cancer in this study and also look at the immune biomarker aspect. Could you tell us a little bit about the Foundation Medicine clinical genomic database, how you identified the patients, how many patients you identified, what you narrowed down the criteria, and the eventual sample size of what you were looking at?
Yeah, so Foundation One has kind of a rich database. They have 2 or 3 things. So one is a genomic database only. So we all, in our clinical practice, I think, send some sort of sequencing, or what we call next generation sequencing or mutational testing for all patients with advanced solid tumors. So all this goes into their database. So all of the samples that are sent to Foundation One, that goes into their database where they know the diagnosis of a patient and they know the sequencing results of these patients. In addition, they also have a clinical database called Flatiron, and Flatiron Health, they have collaborated with them. The Flatiron Health, they have, I think, about 280 or so cancer clinics throughout the country. So a lot of community settings and some academic sites as well, where they not only have obviously genomic database, but they actually have clinical database. They have demographics, the clinical features, the baseline clinical features, the clinical comorbidities, what kind of treatment they received, what was the stage of the cancer, how many months of treatment they received, and their overall survival, and so on. So from that perspective, the Foundation One has access with this partnership with Flatiron clinical genomic database, where they have both clinical data as well as genomic database for a lot of these patients. In our study, we only focus on patients with advanced pancreatic cancer. We excluded a lot of patients who didn't have sequencing results available, or they could not be performed due to lack of tissue. So the first, we talk about the genomic database, and we found about 21,932 patients, so almost about 22,000 patients. And there where we had data on their sequencing, and we also had the data on TMB, or tumor mutational burden. So where we classified patients into 2 groups, high TMB and low TMB. So high TMB was seen in 1.3% of the patient, and about 98.3% of the patient had low TMB. And here we look at the different genomic alteration between the 2 groups. So this is our genomic group, so to speak, of about 22,000 patients. And among them, as we mentioned, that the clinical data was available for about 3,300 patients, or 3,297 patients to be exact. And then after excluding some of those patients, we found about 51 patients who received immunotherapy. And when we say immunotherapy, it was single agent checkpoint inhibitor like pembrolizumab or nivolumab. And then we classify them into, again, high TMB versus low TMB. And then we also look at the patients with high TMB and compare them to who receive immunotherapy versus other therapies. Again, just to recap, so we had about 22,000 patients where we have the genomic database, and about 3,300 or so patients who we have both genomic and clinical data for these patients. And one of the key findings is, again, that high TMB is present in only 1.3% of the patients, or about 293 patients out of 21,932 patients.
Definitely an interesting sample size that you had utilizing this resource, which of course is more or less real world. It is important to gather real world outcomes that you did. So going to the TMB story of this paper, where you looked at immune checkpoint inhibitor use in these individuals, was there a reason why some of the individuals with TMB low were also given immune checkpoint inhibitors? From my understanding, I did see some checkpoint inhibitor used there. What could be the explanation of that?
So this data is from 2014 to 2022. So from the span of about 8 or so years. And as you know, the immune checkpoint inhibitor were approved in the last decade, and there was a lot of not only trials, but even in the non-trial setting, people had tried immune checkpoint inhibitor in frankly different tumor types because of the success in some of the common tumor types like melanomas, lung cancer, and so on. So I agree, as of today, we probably would not use immune checkpoint inhibitor in patients with low TMB or MSS. But at that time, I think that information was not available. So people even with low TMB and MSI stable tumor also received immune checkpoint inhibitor. But those numbers are again low, so it's not very high numbers.
Understand. That makes it a little more clear. Now, you looked at the TMB aspect. I'm guessing you also looked at the MSI aspect of PDAC. What is your understanding, or what was your understanding before this study, and how did it enhance your understanding of the MSI aspect of PDAC? And I'm again guessing, since TMB high individuals are on the lower side percentage, so MSI high is likely to be low as well. Did you see any interaction between those MSI highs and the TMB highs on the PDAC side?
Yeah, absolutely. So we are very excited in general about MSI high tumor for solid tumor because of their response to immunotherapy. Although I would do a caveat because we still don't know MSI high pancreatic cancer, how their responses are, although there have been some real world, very, very small series as well. In this study, one of the things is high TMB totally driven by MSI high, right? That's a question that comes up, and MSI TMB high may not matter. It's only the MSI high that might matter. So definitely when we look at in this patient population, we found that patients, about 36% of the patients who were TMB high also had MSI high patients. So we do expect MSI high patient to have a higher TMB compared to MSS patients. But there were about 66 or 2/3 of the patients did not have MSI high tumor and still had high TMB as defined by, again, 10 mutation per MB. So we did see patients with MSI stable tumor who had high TMB. And I think that was one of our biggest question is, I think MSI high patient, we all tend to think that we would try immunotherapy, even if it's in pancreatic cancer. I think what is not clear, at least from the real world or any of the trial data, is if we were to give MSI stable patient who have high TMB, if we give immunotherapy, is there any responses or any disease control that we see? And that was one of the reasons for this study.
Now, one of the things that comes to mind, and again, I think you based it off on the FDA approval for TMB high, which is 10 mutations per megabase, as you defined earlier. I do a lot of biomarker research, and oftentimes you come across this aspect of binary versus a linear biomarker, in this case being TMB, where, about 10, less than 10. Do you think in general an approach where you maybe have tertiles or quartiles for a biomarker, or perhaps a better approach in trying to stratify individuals who may or may not benefit to immunotherapy?
That's a great point. I think when we use 10 mutation per MB as a biomarker, as a binary endpoint, and do we apply to all tumor types? I don't think that's a fair comparison, frankly speaking. We do know that high TMB, even in different tumor types, do tend to respond a little bit better to, or do have better outcomes who are treated with immune checkpoint inhibitor in different tumor types. But what that cutoff is not known in most of the tumor types. And also, one of the problem is, how do you measure TMB, and is it standard across different platforms? Like, I'm just giving some names like Foundation One, Tempus, Caris, and some obviously like MSKCC and some other like university-owned panels as well. And frankly, I think if you look at different panels and if you send the same tumor tissue, you will get different measurements. So I think the standardization is a problem as well. In one of the studies this involving cholangiocarcinoma, for example, we found that TMB of 5 was enough to have additive effect of immunotherapy, same with chemotherapy, so to speak. But again, this needs to be validated. So you're absolutely correct. I don't know why we use the binary endpoint, but on the same token, the binary endpoint is easy to understand as a clinician. Like, hey, someone has this, do this, not this. And when we look into a continuous range, I think the benefit is obviously vary between high and low or different tertiles, and becomes somewhat challenging. How do you classify patient and what treatments to give? So I think in the clinical decision making, we like the cutoffs, but I think in reality, I don't know if the cutoff is a real true representation. And maybe with the more use of AI or computing, we can just like input some values and then it can tell us like what's the best treatment option might be for the patient. But that's way in the future.
That would definitely be the futuristic approach of incorporating AI, machine learning perhaps, or even digital pathology slides in these individuals to ascertain which individuals benefit. And going back to your paper, could you highlight some of the most important results that you identified as far as which individuals is better, whether it was immunotherapy, and you also looked at some of the mutation, co-mutation status? Could you highlight that for our listeners?
So the first thing we look at is talking about the genomic database of almost 22,000 patients, and then we classify them into high TMB and low TMB, about 300 patients with high TMB and rest with low TMB. And what we found is just talking about in the genomic database that patients who have high TMB actually have low KRAS mutation. So if we think about KRAS mutation in pancreatic cancer, almost 85% or so patients have KRAS mutation who have pancreatic adenocarcinoma. So patients in this subgroup, so in the high TMB group, only about 2/3 of the patients had KRAS mutation compared to 92% of the patient with low TMB had KRAS mutation. So just giving that perspective. So the KRAS mutation, which is the most common mutation in pancreatic cancer and is a driver mutation, the rates very differ from the high TMB group versus low TMB group. And then in addition, in the high TMB group, we found higher rates of BRCA mutation, BRAF mutation, interestingly, and then obviously from the DNA damage repair genes like PALB2 mutation, MSH2 or MSH6, MLH1, and PMS2. So all of these mismatch repair protein mutation were higher. As I mentioned before, the 1/3 of the patient with high TMB also had MSI high. So it's not totally unexpected finding. I think the biggest finding was that we find more KRAS wild type pancreatic adenocarcinoma in high TMB group, almost 1/3. And those tend to have different targetable mutation like BRCA2, BRAF, and PALB2 mutation. So I think one of the interesting findings, I would say, patients in high TMB actually tend to have KRAS wild type or less KRAS mutation. So there's not necessarily KRAS driven tumors, and they have higher chance of having other targetable mutations like BRAF and so on, which we have therapies for. So just always to keep in mind.
Would you think from a DDR perspective, the mutations that you did identify that were more prevalent in individuals that had TMB high, do you think that this is linked to perhaps more DNA damage, more replication stress, more neoantigens leading to more tumor mutational burden perhaps, or is there a different explanation?
Oh, for sure. So, I mean, I think, as we said, like MSI high tumor, they have mutations, the DNA damage repair pathway, and they definitely tend to have higher TMB. So that I don't think was very, very surprising that like PALB2 or other MMR genes like MSH2, MSH6, MLH1, and PMS2, those were at much, much higher rates. I think the interesting finding was the fact of the KRAS wild type and having BRAF alteration, at least that's not suspected to definitely increase TMB, although if we look at colorectal cancer, I think BRAF mutation and MSI high are somewhat correlated. Patients with BRAF mutation tend to have higher rates of MSI high tumors, but that's not the case in the pancreatic cancer. And we also found increase in the BRCA2 mutation as well. So I agree. The DNA damage pathway repair gene alterations is not unexpected because they tend to increase the TMB, but I think the other mutations were interesting.
And I think one of the other aspects of this, which I'm pretty sure you would have thought about, is the germline implications for some of these mutations, where you could very well end up screening not only the individual patient, but also their family members and have measures in place that would try to enhance screening opportunities there. In your current practice, you're at an academic center, but I'm talking about in general, in your experience, how common is it to sequence broad sequencing panels in individuals with pancreas cancer? The reason I ask that is, I do a lot of lung cancer, and even now, despite having all those targets in lung cancer, which sort of paved the pathway for targeted therapy in many tumor types, you still don't see a full uptake for NGS. I do phase 1 drug development, and I get a lot of referrals from outside, and I often see that it's a limited gene panel. So what is your experience for pancreas cancer?
We kind of change our practice. So I similar to you, I'm involved in drug development. So I've been big proponent of NGS for almost a decade now, when we didn't even have targeted therapies, but these companies first came in and they're like, okay, well, very, very low chance. But now obviously we have transformed the treatment for a lot of different cancers, especially like lung cancer. You don't sometimes even start treatment before you get the NGS panel, at least at our institute. So what we were finding is, at least for pancreatic cancer, as you know, the targetable mutations are there, but they are somewhat not that common. I would say in the 10 to 15% range. So many people will get dissuaded and then it's like, what's the point of doing it? But I think for those 10-15% of the patients, I think, first of all, we can really change their treatment course and their prognosis. And secondly, if we don't do it, then they cannot go on the different clinical trials. Now we have trials targeting obviously KRAS G12C, but not only that, KRAS G12D, which is the most common mutation that we see in pancreatic cancer and so on. So it's becoming very, very important. One thing that, at least in our practice, we adopted relatively new, I would say last 2 or 3 years only, is sending liquid biopsies or liquid-based NGS or blood-based NGS testing. What otherwise was happening is I would send a solid tumor NGS from the tissue, and pancreatic cancer, as you know, sometimes a very, very small amount of tissue obtained from FNA. And inadvertently, after 4 weeks, we'll get the result that, there's not enough sufficient tumor to do NGS testing. And then that patient comes after 1 or 2 months later, and then we order the test, and that just delays everything. So now we have adopted a practice where we are trying to send both blood-based NGS and solid tumor NGS at the same time, in the first time of diagnosis, when we see the oncologist at the first time. And that has really increased the rate of NGS testing results for our patient population. And it's not 100%, even in blood-based NGS, sometimes they may not be able to find enough circulating tumor cells to do this blood-based NGS testing, but at least that have increased. But you're correct. I think we still see about 1/3 of the patients who have not had NGS testing, who's referred for phase 1 clinical trial and have gone through more than 2 or 3 line of therapy, so which is unfortunate for our patients.
That's a very interesting perspective on how important it is to sequence these individuals. As you said, it may not be all of them that might benefit, but the ones that have those important alterations, especially BRCA, PALB, KRAS, could benefit from the novel precision medicine-based approaches. A question that came to my mind, I saw that you were trying to look at MYC-MYC in TMB low tumors as well. So what is the role of MYC in the context of these individuals? Is there any drug development that's going on? Because I see small cell lung cancer, MYC is an important target there. These are 2 different tumors, but it looks like there was a hint of some correlation with respect to some of the findings that you showed. Is that something that you're currently looking at or planning to look at?
I think if you just talk about MYC in general, it is again present in somewhat lower rate. I think we found MYC amplification at about 5% or so of actually TMB low patients who had that, and not commonly seen the TMB high patients. So right now, I'm not really aware of trials targeting MYC in pancreatic cancer, but as you said, I mean, if it's successful in lung cancer, maybe that's when we can transform into the pancreatic cancer group.
Of course, we can all learn from each other's subspecialties, and we learned a lot from melanoma with respect to therapy. So hopefully some of the other fields can benefit from each other's experiences in the space of drug development. Well, thank you so much for this interesting discussion. The last few questions are more or less about you as an individual, as a researcher. So could you tell us briefly on your career trajectory, what led you into the space of GI oncology, pancreas cancer, even for that matter, drug development, and some of the advice that you may want to give to listeners who are trainees or early career individuals?
Sure. So I have gone through somewhat different institutions. So during my fellowship, that's when I really decided that I wanted to do GI oncology. Prior to that, I actually have master's in public health, where I learned about epidemiological research and how to design even clinical trials, how to design cohort studies. And my focus was on actually, that was I would say somewhat a luck, but one of my mentors was working on colorectal cancer, and they had this huge database, which is called Iowa Women Health Study database of 100,000 patients or so. So that's where I started really getting into colorectal cancer and GI cancer in general, and how to actually learn from these databases, how to mine these databases, how to do analysis, which seems easy, but is actually quite complicated. During my fellowship, I think the key to is finding a good mentor during the fellowship. And I worked with one of the top GI oncologists in the country who's practicing, and I worked under her. I learned a lot not only from the clinic side, but also from the research perspective, and how sometimes she'll come up with the ideas during the clinic itself, like, hey, this patient has this, and why don't we look into this? And she will even do some of the therapies based on, like, say, phase 2 trials. And she was part of a lot of these trials and learning from those experiences. And following my fellowship, then I joined Moffitt Cancer Center, where I led the phase 1 program there. So I was heavily involved in the drug development program. Some of the training programs I went to NIH and Bethesda just for observership at the CTEP program, and also did the ASCO ACR, the Whale workshop, where you really learned a lot in just like 1 week. So those are kind of opportunities of presence for fellows and even the early, I would say, investigators or attendings as well in the first few years, where you can go there, have your proposal, and they're the world experts in trial design, and they'll talk about how to design trials, how to add correlatives to improve your trial, and you basically develop a whole protocol in a week, so to speak. And then I was at Moffitt Cancer Center for about 6 years. My home was GI, so I did both GI oncology as well as phase 1. And in terms of GI oncology, my main focus was pancreatic cancer and liver tumors. Then I was at Mayo Clinic in Rochester for about 7 or so years. We kind of did the same thing, kind of solidified my career, looking at, again, in GI oncology, looking at liver tumors and pancreatic cancer, and then being a part of the phase 1 division program. And now, most recently, about a year or so ago, I joined Case Western to lead the GI program here.
Are the winters in Cleveland better than the winters in Minnesota?
For sure. I always say you don't know cold till you go to Minnesota. It's a different kind of cold. I'm sure people in Dakotas might say the same thing, but yeah, the cold in Minnesota is very brutal and different compared to any other place that I have been to, at least.
Well, it was great learning about you. Thank you so much for spending this time with us, and thank you for sharing your work with our journal. And hopefully you'll continue to do the same in the near future. Thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
Thank you for having me here, Rafeh. Good luck. Take care.
Thank you so much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.